Hello, everyone. My name is Dr. Bouchard. I'm the founder of the ACHD Hive, and welcome to the new sessions of the ACHD Hive Talks. Myself and Professor La Douceur have put on today a really interesting session on cardiovascular disease risk in ACHD patients. Our ACHD population is aging, and the topic of preventative cardiology is a hot topic now, as per the new updates in the ESC guidelines. And it's made us wonder, should we apply some of these things to our ACHD patients? And to discuss this, we are honored to have Margarita Brida with us today. So she will talk to us about that theme. And then we've got an excellent panel of experts to then discuss further. Any participant is absolutely welcome to raise a virtual hand or write a question in the chat, and then we'll answer as much as we can. But with further ado, Dr. Brida, I'll be really happy to hear your presentation.
Thank you, Melissa. It's truly nice to be here with this nice panel, and I'm absolutely delighted to see Oktay, Megali, Salva, Jolanda, Judith on the panel. Really, you have collected people who are experts in different fields of ACHD, but also I would say beyond, with coronary artery disease and so on. So I'm very delighted to present. I will try to share my screen now. Hopefully that's going to be successful. Right. Can you see my screen here? Yeah, excellent. So as Melissa pointed out, my presentation today should be regarding cardiovascular risks in our population of adults with congenital heart disease. So I have constructed the presentation into, let's say, three main sections. First, just for general audience, to say a little bit about the burden of the disease, that we are truly facing today, a growing and aging population of patients with congenital heart disease. The second part will be more specific regarding the topic of acquired cardiovascular disease and also risk factors that are in general population, but some more specific maybe for our population of patients. And third part would be a little bit how we should address these patients. So starting on the burden of the disease, I think this graph really nicely illustrates that across a certain period of time, we had actually increased birth prevalence of people, children born with congenital heart disease. This is now more or less static, and we expect up to 1% of children to be born with congenital heart disease. So just to put it in a very simple terms, so 1 out of 100 babies are today expected to have some sort of congenital heart defect. And I think it is important to highlight that we do expect almost all of these babies to survive and to reach adult age. And I think this is a very nice graph from Gerhard Diller showing this success story, if you wish, of treating patients with congenital heart disease through different surgical interventional procedures and so on. So today we really expect almost all of these children to survive. Which brings us to the adult population that is constantly increasing, and it's constantly, let's say, aging as well. And this is true for all types of congenital heart defects. While on the other hand, more or less the number of children is relatively stable. And I think it is important to highlight that not only patients with mild or moderate congenital heart defects survive and age, but this is also true even for the patients who were born with the most severe congenital heart defects, such as those with hypoplastic left heart syndrome, such as those with isomerism. So we truly have I would say, growing and aging population of congenital heart disease patients. And this is a very nice graph that was made by Oktay here with us on the call, and Prof Baumgartner published some time ago in European Heart Journal, but I think it is still extremely relevant to really show that we are dealing with rapidly increasing population of adult patients. But not only that, we have more and more population of adults who are more than 60 years of age, and we do expect this prevalence to increase even further as we go on. And in this nice graph, we see that by 2030, the estimated prevalence of adults who are more than 60 years of age is considered to be more than 10%, which is significant. So one can say that this is really a tsunami of patients that we are dealing here in terms of their heterogeneity, in terms of their complexity, in terms of different age groups, but mostly really, really high increase in overall patient population. And of course, we cannot consider these patients to be cured only because we have palliated the congenital heart defect. We know that these patients need many more interventions during their lifetime in majority. They have issues, they have exercise intolerance, they can have reduced quality of life. Pregnancy is the issue in women, especially with more complex congenital defect, arrhythmias, sudden cardiac death, heart failure, and so on. But very importantly, as we all grow older, we are also facing for these patients acquired comorbidities, so coronary artery disease, risk factors, arterial hypertension, diabetes, obesity. So they are not immune to all of these risk factors that we see in general population. So this is why we are discussing these patients now in more detail, because obviously these patients are at higher risk of cardiovascular events. So this is why I would like to start with the second part, which is actually the risk factors in ACHD and acquired cardiovascular disease. Maybe this is the most important slide of my presentation today, because when we compare the general population of similar age with our patients with congenital heart disease, adults, we see that they are more prone to risk factors for atherosclerotic cardiovascular disease, patients with ACHD. We see also that in ACHD, there is earlier onset of atherosclerosis. We see also that there is a higher burden of atherosclerosis in ACHD patients. And of course, there is increased morbidity and mortality if they develop cardiovascular events. So of course, it is much more difficult to treat myocardial infarction in a patient who already has underlying heart issues, so the patient born with congenital heart defect, than it is in someone who was previously healthy individual. So we obviously very much know what are the modifiable cardiovascular risk factors, from high blood pressure, from overweight, obesity, lack of exercise, smoking, alcohol, diabetes, cholesterol, diet, and so on. So in ACHD, obviously this burden of morbidity and mortality is now shifting more and more from the congenital issue towards the actually acquired disease. This is primarily atherosclerotic cardiovascular disease and their risk factors. And this is also true not only for simple patients with simple congenital defect, but also across the spectrum of ACHD. And of course, we have guidelines to help us here in cardiovascular prevention. And this is from 2021 ESC guidelines on cardiovascular prevention in clinical practice, which obviously give us a lot of information how we should address this in general population. But what is actually disappointing in these guidelines that there is no specific reference of this patient population. There is in fact not even a mention of congenital heart disease term across the guidelines. And we did discuss with the ESC and the need to incorporate also this rapidly increasing population into this cardiovascular prevention guidelines for the next time around. But what we did in the interim is that we provided this clinical consensus statement of the working group for ACHD in collaboration with the Association of Preventive Cardiology and the European Association of Percutaneous Cardiovascular Interventions, where we speak about specific acquired cardiovascular disease in this population of adults with congenital heart disease. And if you look on the left-hand side of this graph of this image, you can see that the risk factors, the modifiable risk factors, are in general increase in congenital heart disease patients. So arterial hypertension in comparison to background population is more prevalent in ACHD patients. So of course that is very important for us, for example, in patients with coarctation of the aorta. Moreover, diabetes is also more prevalent in our population than it is in general population. So this is especially true, for example, for patients with Down syndrome, for patients with Turner syndrome, for patients with cyanosis. So this is important to understand specificities of ACHD patients. Psychological disorders are also more prevalent than in general population. In fact, it is considered that at one point of time, every second patient with congenital heart disease has some sort of psychological issues, either depression, anxiety, or some even more pronounced. Dyslipidemia is similar to general population. Obesity is similar to general population, but having said that, it is important to highlight that obesity has truly become a global pandemic, because now almost 50% of individuals are either overweight or obese. And this is true also for our patients. So this is becoming a huge problem in the current world. Smoking is actually the only risk factor that is less pronounced in comparison to general population. However, we do see that the majority of adults with congenital heart disease who are smokers are actually using smoking as, I would say, a compensatory mechanism, and this is mostly seen in patients with limited mobility. So important to highlight, if we go in the middle part of this image, that there is increased risk of risk factors. There is increased burden of atherosclerosis, as I already mentioned, and if they do have cardiovascular events, stroke, myocardial infarction, that obviously morbidity and mortality is higher in ACHD patients. So we do need to start proactively treating this population. And we have acknowledged that, and we now understand that this is why we are here, and this is why we are discussing this very relevant topic. So in the International Journal of Cardiology for Congenital Heart Disease, we actually did a special issue articles on prevention of acquired cardiovascular disease in ACHD. And I have to here highlight again Salvatore de Rosa, who is with us on the call, who edited this special issue articles. And many of people who are on this call actually contributed to this. For example, Jolanda Sabatino did a very nice article on systemic hypertension in ACHD. Then again, Salvatore did an article regarding coronary arteries in ACHD. Megali, again here on the call, Ladouceur did a very nice contribution with ventricular arrhythmias in ACHD, and so on and so forth. So this is a free journal. So for whomever is interested in reading more about the specific preventive measurements, you can go to the journal site under the articles and issues, and you can find all these articles that are very helpful in diagnosing and managing these conditions and risk factors. And I very much like this image that was done by Salvatore. Again, he called it a change of heart, which I think it's very relevant and very nicely actually describes what we are discussing now, that in the pediatric cohort of our patients, we were focused mainly on congenital issues, but in adult cohort of our patients, we are shifting more to acquired cardiovascular issues. So in this position statement, in this consensus statement that we published recently in the ESC, we try to give some sort of general guidance for the doctors dealing with ACHD patients. So we provided this specific congenital heart disease issues that are associated with acquired heart disease. So for example, cyanotic lesions, we know that they that they are at increased risk for diabetes, for example. Then already mentioned aortic coarctations, but also other left-sided obstructive lesions. They have premature coronary artery disease due to arterial hypertension. They have coexisting endothelial dysfunction. So this is important to understand and highlight. For example, transposition of the great arteries after arterial switch operation, we need to reimplant the coronaries. And because of this surgical repair, there is potentially accelerated coronary artery disease. And these patients are asymptomatic because of cardiac denervation at surgery. So they cannot really express that they have, for example, chest pain, which is also relevant to understand when screening for these risk factors and these potential issues. CCTGA and TGA after atrial switch repair, we know there is a mismatch between the oxygen supply and demand because only one coronary artery, the right coronary artery, is supplying the hypotrophied systemic right ventricle. So this also has consequences that we should think about. Moving onwards, for example, patients with Fontan circulation, they can have dyslipidemia, but low cholesterol levels and low HDL levels, which actually can reflect the liver dysfunction, which is obviously prognostically very bad marker. So, so one could think potentially that they are somehow protected, but in fact that could be misleading. And finally, the third part is regarding the management. And I think here important to highlight that treatment and outcomes are more complex and they're more severe exactly because we have the underlying congenital heart disease. Again, we should help ourselves with the guidelines, and we have recent guidelines from last year regarding the management of elevated blood pressure and hypertension. We should utilize also this for our patient population to do at least routine tests as they are indicated to assess for primary or secondary arterial hypertension. We have also the focus update from this year, from last month, published regarding the management of dyslipidemias. And again, we should utilize this these guidelines to help also with our patients, but highlighting that actually our patients are even at higher risk for some events than the general population. So we should be even more vigilant to treat them appropriately. So now we have from dyslipidemia score 1 and score 2. This is for healthy persons or for people who are at increased risk of 10-year major cardiovascular event. So we could utilize also this to help with our patients to see if they are at increased risk, and then based on that to have individual approach in terms of management and in terms of how low we want to have LDL cholesterol, for example, how low do we want to target the arterial hypertension, the blood pressure, and so on. Of course, we need to know some basics, how the drugs and medications work. And today we are quite lucky because we have a really huge diapason of medications to help, for example, with high lipid levels. And I liked very much this prospective study because I think it is relevant when we are talking and considering ACHD patients. This is a sports study that was published in JACC last year, 2023, that actually looked at primary prevention, so healthy individuals who have increased cardiovascular risk. And they were prospectively randomized over a period of approximately a month to either taking rosuvastatin 5 milligrams daily or placebo or any of the supplements. So cinnamon, garlic, turmeric, red yeast rice. Why am I showing this study out of all? Because this is sometimes when in young patients, they are very much not prone to taking medications because they think they can help themselves with some sort of natural, let's put it that way, supplements. But actually this study nicely presented that there was no difference in LDL cholesterol reduction with any of the supplements compared to placebo. And that, of course, only rosuvastatin significantly decrease the LDL cholesterol. So getting back to the consensus statement that we did in the European Society of Cardiology for these patients. So we tried really to provide tables and in a simple way kind of guidance for doctors, for physicians involved with ACHD individuals. And here we provided some general preventive measures in terms of patient education, lifestyle counseling, need for periodic reassessment, need to assess the symptoms on every clinical visit, blood pressure measurement, psychological support, also wearable devices that can really help, especially younger people, to maintain a healthy lifestyle, telling them that they have been sitting too much, that they need to move, they need to walk, and so on. We also proposed the screening for individual risk factors and also the management for individual risk factors specifically for this population. So we propose for overweight and obesity screening and management options for arterial hypertension as well, for diabetes and so on. And finally, we propose some preventive measures to reduce specific risk conditions that are quite prevalent in ACHD. We know heart failure and arrhythmias are the major morbidity and mortality issues. So we propose here some very simple input that we can give to patients in order to try to prevent these issues. So this is my last slide and a take-home message, the same as the previous slide, where I really want to highlight that we are now in a point where we need to really raise awareness of risk factors, that they do exist and that patients with ACHD can also have all the risk factors, and indeed they do have them as general population and even more so. And then if they develop cardiovascular event, that it is much more difficult and with much more devastated consequences than in general population, and that we need to start proactively treating these patients as well. So I will stop here. Hopefully you haven't fallen asleep yet, and I am looking forward to have a nice discussion. I will stop sharing now.
Thank you so much for an excellent presentation. And now we're going to open the floor for any comments, opinions, sharing your experience with yourself, your patients. Have you started screening for lipids, etc.? And if you just introduce yourself before, that'd be great. Thank you. Yes, I see Maria's got a question.
Hi, sorry, I don't know if you can see me or you can hear me.
We can hear
Oh,
you.
okay, thanks. This is Margarita Brida. I'm ICC in Canada now. And I do have a question. When do you consider it's important to start conversations regarding cardiovascular risk factors in the ACHD population? I'm asking specifically within the transition. When they are 18, 20, the first visit, second, third.
Yeah.
Because it's quite difficult the first visit to introduce you as a physician, and then do all the teaching of the congenital heart disease, plus pregnancy or plus contraception, plus cardiovascular risk factors. And they are so used to go out with friends, have alcohol, smoke, and so on.
Yeah. Well, I obviously very much agree with you, Maria. Thank you for this question, that the transition period is truly a good moment to discuss this. And it is definitely not too early. It is right on time in my mind. And obviously the transition is not one single visit. It is a process of couple of visits where optimally in developed countries, they are seen by a clinical nurse specialist on a couple of occasions and discuss all that you now mentioned, from infective endocarditis to pregnancy contraception. But I think we don't need to call it risk factors. We can rather approach it in a more sense that they can appreciate it more, I would say, healthy lifestyle choices, exercise, diet, and so on. So I do agree with you, Maria. Definitely, we need to start even from younger age, I would say, even in pediatric population, because we know that the majority of overweight and obesity even starts in pediatric population. So the discussion with parents, with family, alongside with young patient in a way that they can obviously understand that this is balanced for them, should start even earlier, I would suggest.
I don't know if it happens to you, but I try to use the statement, you have enough going on with your heart and you don't want to add more diseases or more treatments or more medications. So it's better if you keep you healthy. But sometimes what I feel is like they don't worry, they are too young, and they want to go to university and have their life. So yeah, trying to enroll them in physical activities, maybe like I found that would be like, that's kind of easiest than speaking about cholesterol or hypertension or diabetes risk, especially when they are like borderline overweight.
I think it is important to highlight that we need to approach every patient individually. It also depends on the level of education. It depends about where they live. It depends how old they are. We need to make sure that we are discussing with them at the level that they can understand and they can adopt. And this is this, I would say, stepwise approach where you cannot obviously burden them with too many things at a single visit, but have to prioritize what you think at this moment is the most important one, and then slowly on the subsequent visits to address other issues.
Thank you.
Thank you, Maria. I was actually hoping to hear a little bit from maybe Jolanda and Salvatore, because you had this really nice contributions in the International Journal of Cardiology for Congenital Heart Disease. And Salva, you were talking about coronary arteries, which are becoming more and more an issue also in our patients. And you being an interventional cardiologist, how do you deal with this? And Jolanda, hypertension with diabetes, hypertension with obesity actually is the most prevalent in ACHD. So I actually really enjoyed reading your paper about the arterial hypertension. And we know that there are many conditions that are at high risk, which is somehow connected with Salvatore's article. So maybe you can give us some key messages how to deal with those patients.
Yes, of course, Marga. I should start echoing what Maria just told us, because reading there is a very nice for the ones who didn't have the chance to see it already. There is a very nice paper recently published on the European Heart Journal on Cardiovascular Prevention by Margarita's group, highlighting some gaps which are mainly cultural, let alone some logistical gaps uh, that are just avoiding the best cardiovascular prevention among these patients to come forward. And it was quite surprising. I enjoyed the article very much because it was quite surprising to see a sort of paradoxical result. Because on one side, you have a lot of patients who are not entirely aware of their heart condition, congenital heart condition. At the same time, they might overestimate the congenital heart defect burden on their lifestyle and prognosis. So even they estimate in some cases even worse prognosis than the one their physicians are telling them. So we are talking of patients who are regularly seeing their physicians. And this is one of the reasons probably these results are based on a Central and Southern Europe sample of patients, but I have the impression this pretty much extends to what up to other geographical regions. I mean, we have different issues and different problems to solve in any of our geographic target areas, but many cultural problems have something in common. But what can we do then? We have seen from this very short but very full of hints presentation that we have another representation of some risk factors, but we also have an under-treatment of other risk factors. For example, we have a similar prevalence of dyslipidemia among ACHD patients, but we know very clearly that this is a general problem with dyslipidemia, also in non-congenital heart disease patients. They are not persistent on their treatment, but this problem is even larger with ACHD. So we know that we have an underestimation of the cardiovascular risk factors. We know that we have an under-treatment, and we also have sometimes a lower availability of prevention program, which I think Margarita highlighted this very well, might be as much personalized and individualized as possible because of the many regions we are very aware of, younger age, long lifespan, where they are going to take care of their cardiovascular health. They need to start earlier because we know that they are developing the same degree of acquired cardiovascular disease, but still the treatment might be a bit tricky and as compared with the usual anatomy. So this is a very important point. What can we do then? Very briefly, cardiovascular risk factors should be assessed very early and at any chance. So any cardiologic visit should be one opportunity to do so. We don't have specific risk factor for adult congenital patients, but we can still use those that are available for the general population and that are suggested by European Society of Cardiology guidelines, like the SCORE2, for example. And also another very important step is to identify specific high-risk groups, such as those with prepaid aortic coarctation, systemic right ventricle, or those who underwent a transposition or underwent an arterial switch after for a transposition. And we have to promote a healthy lifestyle, but this must be a lifelong a lifelong activity. This is very important for them to understand. But nowadays we have, for example, wearables or digital tools that can help these patients, and they are at an earlier age than the general population. So this might be the appropriate population target to start using digital tools among in the cardiovascular field. And we should remember that hypertension is very important in this patient, as diabetes is, but also not forget about those risk factors who might be undertreated, like, for example, dyslipidemia. We know that statins are really underused, and also antihypertensive, and these are two of the largest concerns about the management of cardiovascular risk in these patients. And education. Again, we go back to the cultural problem. We should improve education, not only of patients to increase their responsibility and their active engagement in managing their cardiovascular health, but we should also promote knowledge about congenital heart disease among the general cardiology colleagues, because this is very important. The number, the data Marga shows this very clearly. The numbers are growing, and this means that the chance to have patients with congenital heart disease in your visit, in your cardiology office, even though you're not an expert on ACHD, is concrete nowadays. So this is very important, and so to have a very brief summary, I think we should act very early. We should be very strict in cardiovascular prevention in this patients group, and we should provide an individualized, a personalized approach.
Thank you for this great and relevant remark. We have additional questions in the chat, and I think they are very interesting. Notably, does everyone check lipid profiles in their patients, men over 40s or women over 50s? And should we consider screening there earlier, seeing as our population seems to have higher cardiovascular disease? Should we change the threshold to control cardiovascular risk factors, including lipid profiles and risk of diabetes, for example? And Dr. Bouchardy say yes, we should screen. But with which goal? Is it the same goal than in the general population, because they are more risky due to their congenital heart disease condition, and with same as the primary prevention, as I said, and even in patients with reimplanted coronary arteries, should we have the same goal for them, or should we be more active with high-risk patients with the LDL level, for example? This is a question, and I think also that we have to communicate with GP about his risk. We need your opinion on the panelists about this.
So I can maybe briefly respond from my perspective, but then it would be good also to hear others. So my personal take, what I do is on a single occasion when they transition to adulthood, I do all the initial, let's say, baseline in adulthood blood work. And in that sense, I do include the lipid profile. It is more screening for, excluding familiar hypercholesterolemia, some very prominent issues. But also we already have quite overweight and obese adults transitioning, so it would be good to assess this at an early stage. However, if you have a general person and everything is fine and he is normal weight and with normal blood pressures and mild defect, obviously after that I do not anymore do these tests. And then after the age of 40 or 50, I just follow the guidelines and according to that assess them. So yeah, this is from my side, I think very simple approach but would like to hear Oktay. Maybe you have a big pool in Germany.
Yes, so currently we're sticking to the guidelines, so we're recommending screening and these patients, and if you have high risk patients like lactation, we make sure that they understand that optimizing their cardiovascular risk factor is essential for the outcome. To Judith's question, should we kind of have different goals and treatment goals for patients? I don't know. We don't have any data about that, and I think it would be a good first step if we even reach the normal recommendations, and I'm quite sure that, and a lot of studies have shown that we don't even screen in our patients, which should be screened. And there's data from Boston showing that, and also data from Germany. So we should start with what's already there. And if we kind of get into the perfect place that we kind of screen every patient according to the guidelines, then we can kind of think about new cutoffs and earlier screening. And this might be the next step. But I think it's very important to kind of even start screening in the population which is clearly at risk, with or without having a congenital heart defect, which is the elderly population or the population over 40 or 50, whatever cutoffs you will choose from the guidelines. And I think it's, as pointed out beforehand, it's really important that we start early on with lifestyle changes, because I mean, it's everyone's experience. Everything you start when you're young, like exercising, healthy habits, whatever, it's much easier to kind of include in your daily life and get adapted to it than if you have to start it after 50 or 60. It's much harder.
Yes, I think very interesting, Oktay. But we also there is also a very cogent issue, and I think you did hit the pain point right away. Should we use the same targets as the general population? Probably not, but we do not have enough data to support this. What we can do, however, is to select our high-risk subgroups. You mentioned, for example, aortic coarctation, and do a more strict screening of those patients. For example, how many of you regularly measure lipoprotein little a on their first encounter with these patients? This might be very, very useful, because this might underlie a higher risk than, and then you have a tool to increase the lipid lowering treatment, or for example, go and search subclinical atherosclerosis, like an intima media thickening, or using many of the tools we have nowadays. Of course, this requires access to these tools, but many of you are working in large hospitals, so I'm sure you have the opportunity to see. And then, meanwhile, we should probably promote some actions to include specific anatomic conditions among the risk stratifiers. Now, we know very well that, for example, if you have diabetes or manifest arterial atherosclerosis, you immediately jump to the high-risk group. Might be the case for some very specific ACHD subgroups. See this as a question mark. We do not have the data, but maybe based on a consensus, we can then go to the public payers and ask for an action to them, because this really has the potential to improve their quality of lives and increase life expectation, and finally reduce public health system costs.
Totally agree, but I think it's not only a public health issue, like that, like the system doesn't want to pay for it. I think it's an awareness issue. It's even between us ACHD doctors, many of us are not aware of that problem. So it's, again, also with other comorbidities, it's quite the same, because we are used to look just at the congenital heart defect and make sure that everything is fine and the plumbing is right and whatever. And we don't look at comorbidities only if they kind of affect the heart. And in the last 10 years, start to realize it's very important to look also at comorbidities like Kostas Dimopoulos' paper on renal failure and stuff like that. So I think it's also an awareness issue. I do get your point, and I agree that probably our patients need different targets, but I think it would be a great step if we could just go out and make people aware that there is this problem, and we should take care of this problem and take a look at the whole patient and not just the congenital heart defect in itself. So I think this would be a good start. And then I think it depends on which system you're working, because in Germany, for example, many ACHD cardiologists are pediatric cardiologists. So they're not used to look after cardiovascular risk factors, coronary heart disease, hypertension, stuff like that. So it's kind of a learning process for them. So it's much easier if you have other cardiologist background like myself. So it's kind of because they're kind of trained and used to ask for lipids and stuff like that. So I think it's very important to raise awareness.
I think this is excellent discussion, and actually I like, Oktay, what you highlighted, the fact that yes, of course we can think about specificities for ACHD, but in reality even the baseline guidelines are not yet established and followed in this patient population. So I think this is really important that before we start thinking further ahead, we should at least have optimal blood pressure. We should at least have, as Salva mentioned, optimal cholesterol levels. So I was really wondering to hear from Jolanda, about the arterial hypertension. It is a huge problem with obesity, and then we will go to Judith, because Judith, you mentioned very important now this novel obesity medications. But these are two main issues, and how to tackle this. One would say in 21st century in the developed Europe, arterial hypertension should be treated optimally, but we know that this is still not the case. And especially in patients with ACHD who have systemic ventricle failure, we know that the blood pressure should be low. With patients who have aortopathies with dilated aorta and so on, we know that the blood pressure should be low, but are we treating them accordingly? So Jole, maybe a comment from your side.
Thank you, Margarita. I agree with you, Oktay and Salvatore, Melissa, that there are no data suggesting that a tighter control of blood pressure is needed in congenital heart disease patients, but maybe we need to design a new trial on this topic, because of course regular blood pressure monitoring is suggested for an early identification of hypertension in these patients. And once confirmed, they should be treated using different strategies, from lifestyle modification to medical therapy. And this is true also for children. We should start early. The earlier, the better. Hypertension in congenital heart disease patients is common, and with multiple etiologies. You mentioned coarctation of the aorta, which is the paradigm lesion, with hypertension developing in up to 60 to 70% of adults, even after early repair, for aortic stiffness, reduced distensibility, intrinsic wall abnormalities, surgical technique, residual obstruction, and so on. However, structural arterial abnormalities have been demonstrated in other congenital heart disease lesions, such as tetralogy of Fallot, TGA, single ventricle, and so on. Aortic stiffness is also documented in bicuspid aortic valve, Williams syndromes for supravalvular aortic stenosis, renal stenosis, and Turner syndromes, and so on. There are also systemic contributors for in this specific population, such as cyanosis, erythrocytosis, chronic kidney injury, And of course, there is this issue of sedentary lifestyle that is common even in pediatric age, and obesity further increase the risk. Of course, persistent hypertension after CHD repair contributes to premature atherosclerosis and increased mortality. So maybe a lower threshold for risk factor screening and intervention is needed.
Which actually nicely brings us to Judith's point about obesity, which is becoming extremely huge problem. And you mentioned the novel semaglutide, and I don't know if you mentioned Mounjaro, even more potent one. Judith, maybe what is your thought to reverse the question back to you?
Oh, I think it's very important because some of them, they really have the whole metabolic syndrome. And if you have them at the clinics and you said, okay, you should lose weight, do some sport, stop smoking, stop drinking alcohol, and do all that, and I'll see you next year. Some of them will never see them the year after. And we have to take the thing one after the other, and we have to give them some solutions to help them. And I think that in some selected patient, GLP-1 agonist would be a good help, because then it can help to decrease the weight, but also help for the blood pressure, help for diabetes. And the less they wait, the more they wanna move. And at some points, when they're really obese, they can't move anymore. So it's nice to tell them go running, go swimming, but they can't do it. So I think that not only should we screen for risk factors, but we have to go with solutions and try to help them, because if we leave them just by themselves, it's too much.
I completely agree. We actually have now under some submission paper, the team knows from the working group here that we'll see where we're going to manage to publish it. There is very little data on weight lowering drugs in ACHD, but I think this is very much needed for all the reasons that you highlighted, and also some syndromic patients with, for example, Down syndrome. Yeah. You cannot make them exercise. They are not compliant with this, and they are in some circumstances quite petite in stature. So obesity is really becoming an issue, and we need to do something. And here potentially we discussed that there is little data, but there are now emerging studies on weight lowering medications also in ACHD patients, and initial studies did show that safety seems to be okay. Yeah. So I completely agree with you that this is the next step, and we should have more data on this, obviously, but here maybe it's a good platform to Oktay and Melissa being together now in Berlin, or maybe people who can start thinking about prospective international study on these drugs in ACHD to have more data. I think that would be very much needed.
Yeah, we are already using them in our patients.
We are.
And some of them, it's like the general population, some of them do profit from them, so they lose weight and are on a very good way. Some of them just stay on the weight. So it's kind of, you have no responders for whatever reason. And but yeah, we're using them more and more, and I think it's important that we have them. Yeah. It's not kind of the solution to go straight ahead to it. So I would agree with you, Melissa, that we should also send them to nutritional advice and stuff like that. But as you said, Judith, it's kind of, if you're weighing 150 kilos, you can't tell them to go run a marathon. That's just not possible, not feasible. They can't even move from the tube station to the hospital. So it's kind of, you have to find a way to help these people. And but we should totally agree with you, Margarita. Should look at the data and combine it, and maybe do some prospective work on it. So, Melissa, for your to-do list, for your bucket list. No, I think there's a lot of work to do there. Yeah, and we should adapt it. I don't think any safety issues, because there are studies which show that they improve cardiovascular outcome in really high-risk cardiology patients. So I would anticipate any broad safety issue in our patient population.
Yeah, and I also think that we should use everything that we have. Let's say for high blood pressure, we have some devices that they can wear, and then they have an app on the mobile, and they can check whether they have high blood pressure or not. And I think that for our young and not so young patient, it's better than just to take one single blood pressure measurement that can be high due to stress, due to anxiety of being at the hospital. As if they have a wearable device they can have at home and check on an app, that will help them, and it's something that they like. So I think that we should adapt to the new technologies and the new medication, and try to help them, and not just let them know that they have high blood pressure and that they should deal with that.
Yeah, and I think without doing any advertisements for anyone, the new Apple Watch has kind of this built-in, like, detecting high blood pressure, whatever that means. So I think it's already FDA approved, Amy Bad. Kind of put that on LinkedIn. So it's kind of will be interesting. I think the technology is getting better and better, and so I totally agree with you. We should adapt to it and use it, and because our patient population is generally younger than the rest, so they're more prone to adapt to these new technologies. So
I think our population is, I think, probably a bit more aware already of the cardiac issues compared to the general population, and I'm sure that they would probably welcome to be more responsibilized and empowered with apps and etc. Any last remarks before we have 3 minutes left to close the session?
Just a small comment on what you said. I think the big advantage in our patients, at least for those who are not lost to follow-up, is that they come and regularly visit a cardiologist, an ACHD cardiologist, so they are at least in contact with the healthcare system, so we can do screening, stuff like that. Many other patients, and that's Salvatore knows that much better than myself, are never seen by any doctors unless they get their heart attack, and then it's maybe the first time that someone measures their cholesterol. So we should try to use this advantage we have for our patients.
Yeah, I think we have more of a preventative way with we've got a bit more of a chance to actually do prevention, as opposed to the general population. As you're right, they come when it's too late. Well, thank you so much, everyone, for these really interesting discussions. And clearly, we've got lots of research to do. We can all work together and all be skinny and athletic. So we will be posting this session on the website. And thank you again for all of you for coming along. And I hope that we can discuss further research and potentially some changes in our practice.
Thank you, Melissa. Thank you all.
Thank you.
Thank you.
Thank you. Thank you.